Hello, everybody. Thank you for your patience with our technical difficulties tonight. One of our group norms for support groups is always be patient with yourself and others, and technology may and usually does provide issues thanks to the pandemic. We can just blame the pandemic for everyone. Welcome tonight. I am so excited for you to join us. My name is Christy Horner. I'm the founder and executive director of Courage to Caregivers. We're a nonprofit that started here in Cleveland, Ohio, but now serves caregivers throughout North America. It started because I supported my brother who lived with anxiety, depression, and obsessive-compulsive disorder for 4 years. My sisters and I were his primary emotional and mental support caregivers for 4 very long years. And what we realized during those 4 years is that it was a very lonely, long, and hard journey as a caregiver. Ultimately, we did lose our brother. He lost his battle to mental illness, to suicide in 2014. And from our journey, we realized no caregiver should have to take that alone. And so we bring you this program tonight with so much heartfelt thanks to all caregivers out there who are struggling, who are stuck, who feel alone, because we're so glad you found us. So I will now introduce and bring on my colleague, Jenny, who will introduce herself, and Dr. McIngvale, our speaker for tonight. Thank you again for being with us.
Hi.
Excited to be here. Thank you for having us.
Oh, it's wonderful to have you. Give me a minute to get myself together here. Too many tabs. There we go. Excellent. Thank you, everyone. I'm so sorry. It sounds like there's been some miscommunication about where we were holding this talk. Oh, I need to mute myself on this screen. Sorry, Nicolette. Again, apologies for that. Sorry, some questions about where we were holding this talk. I really do apologize about that. I thought I had deleted the Zoom meeting, but it came up for some folks. So most of you are in the right place, and I apologize to those of you that aren't. Let me pull this up. Okay, excellent. Well, welcome again. I'm Jenny Woodworth, a licensed social worker and director of programs for Courage to Caregivers, and I'm so glad to be with you tonight. We're recording this program, and if you aren't here live, again, due to that error, I apologize, or you had to see it at another time, know that we're recording this, but only Liz and I will be shown here. We may not have time for live questions. Know that we did receive questions submitted prior to this event, and we will include as many as we can. We will not be able to include all of them in this presentation due to time limitations. So I'm hoping we can provide some information about what happens next with those questions, that we can get those answered for you. Let me take a minute to tell you a little bit about what Courage to Caregivers does to support family caregivers. Courage to Caregivers is a nonprofit located in Northeast Ohio with the mission to provide hope, support, and courage to caregivers and loved ones of those living with mental illness. We focus exclusively on the caregiver and see ourselves in the caregiver burnout prevention business. We offer 3 programs, currently at no cost to the participant. All programs are now virtual. We are now supporting caregivers nationwide. So these are the programs we offer. One-to-one caregiver peer support matches caregivers in need with trained volunteers who have experience caring for someone living with mental illness. Just a shout out, if you feel compelled to help other caregivers, I always need volunteers for this program. I'd be happy to talk to you about that at another time. Our weekly support groups are co-facilitated by both a licensed social worker, counselor, and a trained peer specialist. Our support group model provides essential tools to build a caregiver's resilience. While staffed by professional therapists, we do not provide therapy or counseling. These are more like coaching sessions. And last of all, and probably the fan favorite in many cases, breathing meditation facilitators are credentialed yoga instructors that incorporate breathing techniques, light yoga movements, guided meditation, and a deep rest, typically a yoga nidra. So I know many of you on this call or this talk are supporting adult children. I just want to give another shout out quickly to the parents of adult children with OCD groups out there. We're big fans, of course, of the support group model and have partnered with these groups in the past. These are parent-led groups that provide parent-to-parent support to parents of adult children with OCD. It's a safe place for parents to connect with each other, share our experiences, ideas, and resources, and receive compassionate support from other parents who are on a similar journey. Reach out after the talk, and I can broker a connection with the parents that run these. I also want to thank Doherty Construction for sponsoring this talk. And now, what you're here for, I would like to introduce Dr. Elizabeth McIngvale. She is the director of the McLean OCD Institute at Houston and on faculty at Harvard Medical School in the Department of Psychiatry. Elizabeth founded the Peace of Mind Foundation, now a part of the International OCD Foundation, and helps run OCDchallenge.org, a self-help website for OCD. Elizabeth was the first ever national spokesperson for the IOCD, where she now serves as a board member. She was diagnosed at 12 with OCD and engaged in inpatient and outpatient therapy. Dr. McIngvale engages in clinical work, research, and advocacy with the goal of improving access to care and OCD treatment to make a difference in the lives of those with OCD. And I'm going to talk a little bit about McLean. At Houston, we are dedicated to offering a compassionate, therapeutic environment while implementing evidence-based mental health care to provide the most effective treatment outcomes. We specialize in cognitive behavior therapy, also known as CBT, particularly exposure and response prevention ERP therapy, in addition to other proven treatment techniques such as mindfulness and acceptance and commitment therapy, ACT, for individuals struggling with anxiety, OCD, and related disorders. Our program is ideal. Sorry, I lost my place here. What happened here? Oh, I'm just going to start over. I apologize for that. Our program is ideal for individuals with obsessive-compulsive disorder, anxiety disorders, OCD, excessive-compulsive spectrum disorders, phobias, and depression. We offer multiple levels of care, including partial hospitalization and residential support for adults, intensive outpatient care for teens, and outpatient services customized for individuals across the lifespan. Learn more about their treatment options at a link that we'll provide later. We also work to advance the treatment and outcome research in the field of OCD, anxiety, and related disorders. Our findings demonstrate that our patients in general benefit greatly from receiving treatment and our treatment programs with care that is designed to fit their individual needs. Okay, excellent. Well, Liz, welcome again.
Thank you. Thanks for having me.
Yeah, this has been such a wonderful opportunity, and I'm really excited to be with you tonight. So I'm going to jump right into it. What's the best way for a parent or other caregiver to be involved in treatment?
Oh, it's a great question and a loaded one in the sense that it really differs case by case, right? So the first question I'd want to say is how old is the individual living with OCD or mental health condition? If they're under 18 and they're an adolescent, you should be an active role in both the treatment and all of the support process, right? What we often find is that when we're treating kids and adolescents, we're also treating the parents. So the parents should be actively involved in the treatment process, because what we know is that the parents often are a big part of individuals' OCD if we're talking about OCD. So whether that's through reassurance seeking or enabling behaviors like cleaning rituals or whatever it might be the parents are helping the kids with, we need them to be an active part of the treatment process or our outcomes are going to struggle. If you are an adult, a caregiver of an adult, I think it depends situationally on that adult's level of independence, right? If it is an adult who's living independently, right, maybe their parents play a supportive role, and it's really important to definitely, no matter what, get a good education and understanding on the treatment process, and how to support versus enable. Mm-hmm. If we're talking about a college age student, for example, where the dependence is much higher on, probably on their parents or caregivers, the role might look very different. And of course, if we're talking about an adult living at home, an adult who is struggling at a level and has been struggling for a long time where the parents play an active role, in that person's life and in taking care of them and being an active caretaker, then you're going to also need to be an active role in treatment and play an active role in treatment.
Okay, excellent. And this is kind of a two-part question. And when I first put this one down, I was like, because I always want to focus on strengths, but I get that sometimes people want to know what are some of the common mistakes that parents or caregivers make, and what recommendations do you have to be supportive, but again, not accommodating to your loved one with OCD?
It's a really hard question, because you accommodate because you love them, right? You're not accommodating because you don't love them or you don't care. And when we think about OCD, what we often find when we get appropriate treatment is that what we were doing in an effort to help and to try to fix or alleviate the anxiety and symptoms often actually contributed to the OCD cycle. And so you have to really relearn what support looks like, even sometimes what that relationship looks like, because you're rebuilding it in a very different way. With that being said, I never want a family member or caretaker to just stop what they're doing overnight because they're like, oh, I'm enabling versus helping. Like that isn't useful. We want you to do that together in treatment, and we want it to be something that we're both bought into, we're both on board with, as far as the patient and the parent, as well as the treatment team. So I think that caregivers, here, let me say this. If you're on this talk, you're probably doing things right, in the sense that you are their advocate, you are their loved ones, and you are often being a voice for us when we don't have a voice. And so, it's hard to say what we're doing wrong, right? But what I will say about OCD, the only thing I can say is try not to use too much logic to talk somebody out of it. Right? So sometimes we see a lot of times loved ones, people we care about, are telling us things like, well, that doesn't make sense, or it's irrational, so why are you doing it? But the nature of the disease is that we engage in behaviors even though our thoughts are irrational. We know that. So try to not get too stuck in debates and logic about why they're doing this, and instead try to focus on how to support them through it and what that would look like. The second piece is that I think caretakers, right, often feel that if I don't enable, it feels like I'm being harsh, or it feels like I'm being mean, right? If I don't do what they want. There are ways to not enable and be supportive, right? So one of the things I always say is, can we say something like, I love you, but I don't love your OCD. And so I'm happy to spend time with you right now, but I don't want to ritualize with you because I know that just makes OCD bigger, right? So there's ways to be supportive and set boundaries. It doesn't have to be black or white.
Okay. So thanks for focusing on strengths for a second too, that if you're on this call, you are probably totally doing things right. I agree. I wonder also and again, I wonder if you could answer this in two ways. And again, I hope this isn't springing it on you, but what should you do as a parent if your child's refusing treatment? And also, what about those folks over 18? Any ideas for those people that are, helping? How do you help people get treatment if they're refusing?
Tough, it's
two different populations.
Totally, yeah. So I mean, first and foremost, when we're talking about somebody who's under 18, you have I want you to hear the second part of that question. What do we do when they're over 18, right? Because we're in a different boat. And why I say that is that when someone is under 18, you get to make some of those decisions for them. Yeah. And if you have an opportunity to make a decision for somebody to seek evidence-based care, but they're not able to make that decision for themselves, you should absolutely capitalize on it, because once they're 18 and it's a lot harder for you to make those choices for them, you're in a much more difficult spot. With that being said, treatment shouldn't be punishment. And so I really, if you're a parent of a child with OCD, it shouldn't be, if you do that, you're going to go to treatment, or, you're going to go to therapy, or, therapy should be something that it's support, right? It's something that you do just like exercise or other things, right? It's good for you. It's healthy for you. It's non-judgmental. And can we make it a really safe, even fun place, right? Kids should find therapy to be kind of fun and exciting and enjoyable, because it heightens their strength and their courage. If they're an adult with OCD and they don't want to go to treatment, there's not a lot you can do in terms of forcing them to go to treatment. True. But what you can do is help provide appropriate education, support, resources, connections that may make them be more open-minded to considering treatment. So I always recommend visiting IOCDF.org, joining support groups, helping give them opportunities to watch webinars and learn from other people like myself and other advocates who speak openly about our journey, because if we can start to destigmatize OCD and OCD treatment, it might not feel so scary. The other option as a parent is, can you consider or, negotiate going with them, right? Like, I'd be willing to do this with you. We can do this together. It doesn't have to be you have to do this or not. And then the last option I want to talk about is there is a new incredible treatment intervention called SPACE, and it's all caps SPACE by Ellie Leibowitz, and it's designed for caregivers. It's designed for family members versus the individual suffering. And so if your loved one isn't willing to seek treatment, you can actually engage in this protocol, which helps walk you through the steps you might need to take to either set boundaries and or encourage them to seek treatment.
Oh, wow. I haven't heard of that. So SPACE, like all caps.
SPACE, all caps, and it's specific for OCD. It's a specific training for anxiety and OCD. You can go to their website and look up providers near you that are SPACE certified.
Excellent. And whatever comes after this, as far as information that we put out afterwards, I'll try to link something on that for folks that are watching and curious, because I'm curious as well. So
absolutely.
All right. Excellent. Thanks for your answer. Thanks for the, the tricky over 18. We get that a lot. My child is 19. Like, well, yes. So again, that the role of support and resources is where you go with that, I guess. Great.
For sure.
Okay, so what can a parent or caregiver expect from sending their child to higher, or the person they're caring for, to higher levels of care? So again, such as that IOP, which is intensive outpatient for those that haven't heard of that, or residential care, which would be inpatient. And after that intensive treatment, what are the best ways to maintain gains? So expectations, and then what comes next?
Yeah, it's a great question. And I want to actually, before expectations, I want to talk about treatment options. And when we think about higher levels of care, when we're talking about OCD, obsessive compulsive disorder, we're talking about a mental health condition that, in order for treatment to be successful, it really requires a specialized treatment intervention. So you heard Jenny talk about earlier, both my personal and professional background with exposure and response prevention, which is the specific form of OCD treatment that it falls under the CBT umbrella, but it's specific for OCD. I caveat things with that because I want you to be careful that standard higher levels of care may not be really beneficial for OCD. And what I mean by that is finding a generic mental health PHP, if your child is suffering with OCD, that they need OCD treatment on a higher level of care, is not going to help them move the needle the way it will if you find OCD specific higher levels of care. So there are, like our program here in Houston, there's different programs across the country that specialize in OCD, both on an IOP level, PHP level, or residential level. And so I certainly recommend, when we're talking about higher levels of care for someone living with OCD, that it is a specialized OCD program. With that being said, if that's what it is, the OCD programs, I don't know of any who are specialized OCD programs that don't encourage and or require family involvement in the treatment, right? If you come to our program, it's family therapy once a week. Our family therapist is an active member of the team and of your care, and that y'all should be working collaboratively to come up with a support plan when someone leaves. We would never expect that family members aren't aware of what the expectations are, but also aren't becoming educated themselves through our work and able to understand what support versus enabling and how to help this individual. The reality is that relapse prevention should start on day one of a higher level of care. It shouldn't be on day of departure, right? You should be talking about how we're going to maintain these gains. What is it going to look like, right? How is the home environment that previously might have been triggering or enabling going to change when we come home? And so it should be an active part of the entire treatment process for somebody who is in a higher level of care. And if it's not, I'd want you questioning and asking those individuals why it isn't, because it really needs to be, right? If we make great gains here, but the individual goes back to an environment that allows, or that used to be really triggering, that those triggers haven't been addressed, it's going to be tough for them to maintain the gains they made here.
Oh, great. Okay. Thank you. So I'm in Ohio, and I've often heard that Ohio can be challenging to find care for folks that are living with OCD. And I know there's people on this talk from all over the country, and hopefully there's care, wonderful care in other parts. But in case there isn't, what should you be looking for and asking for when you're seeking a provider? And if the caregiver lives in a state with limited resources for OCD, what recommendations do you have to advocate? So this is a big macro question for you, for better services in that city or state. So many of these are two-part questions, Liz.
Yeah, no, it's great. This is the most important question you can be asking yourself is, how do I know that my loved one is seeing somebody who understands OCD? And then also, if they're seeing someone, what should I expect and look for? But more importantly, right, what you're asking is, how do we find that to begin with? And so there are incredible resources like the International OCD Foundation, where you can go to IOCDF.org and click Find Help. You can put your zip code and providers will show up, right? There will be a list of providers. That does not mean that every provider that shows up is super qualified, right? Because IOCDF, they're not able to vet every provider, right? It's not a recommended provider list. It's just a provider list. You have to do the vetting. And so it's actually quite simple. What I want you to do is I want you to ask one question, which is, what treatment do you use to treat OCD? You know, if you say, do you treat OCD? And they say yes. Okay, what treatment do you use? If on their own, the provider does not say exposure with response prevention, I want you to say thank you very much and hang up the phone. I'm serious. If they say CBT, if they say supportive therapy, that is not the correct answer. If somebody doesn't say ERP, they have not received specialized OCD treatment or training. Sorry, not treatment, but training. And so they're not going to be equipped to treat. The good news is with COVID, you know, there's a lot of negatives, is that it has really actually expanded our opportunities for people to access good care in two ways, right? Virtual therapy options give you the option to access people from across your entire state, wherever you live, versus in your city only. And then also there's organizations like SIPAC, where psychologists can be a part of SIPAC, and that allows their license to be good in multiple states versus just the state they're licensed in. And so the ability to be able to work with a licensed provider is much more broad than it used to be. And so it doesn't have to be so inclusive. So it can be hard, there's no doubt. But there are providers out there, even in Ohio. One of my old clinicians actually is in Ohio treating OCD. And so I know they're there, right? They're there and they're incredible, but be strategic, which means make sure you're asking the right questions. IOCDF.org, which is also listed in the comment box that you'll see in the pane on the right, you can also on their website search for what to ask providers. And there's a beautifully written article where they lay out some important questions that you would want to ask providers that would help you know if they have appropriate OCD background.
That's wonderful. Going in with a plan. That can't be denied.
Because, you know, the thing is that in mental health in general, and many of y'all know this, and it's unfortunate, people can say, because they go to school, right? We can say, oh, we can treat all these different disorders. I will tell you, it is a red flag if a provider says they can treat more than, 5 or 6 disorders, especially if they're within different categories, right? Yeah. Can I competently treat OCD, anxiety, and all the related disorders? And if I listed every one, like social anxiety, generalized anxiety, panic disorder, would it be exhaustive? Sure, maybe. But it would be impossible for me to be a specialist in what I do, which is OCD and anxiety, but also a specialist in schizophrenia or a specialist in bipolar, right? Like, there's only so much appropriate training and specialized treatment and care that you can get or understand or be a part of to be a true specialist.
Okay, thanks for that. So how can a caregiver best avoid participating in rituals and reassurance?
We can ask my mom that, and she will tell you, like, it's not easy, because again, what my mom would tell you is that I want to be Liz's mom, not her therapist. And she, and just like my mom, who, I've personally dealt with OCD, but, professionally, I don't want you getting into debates, and I don't want you playing this like clinical role. You shouldn't be doing that. Why are you doing this? You should be doing this instead. Because again, now we've got all this conflict in the house around treatment that I'd rather the provider be the person navigating that and you be able to be their parent and support them. With that being said, when we talk about not engaging in rituals and not engaging in behaviors that increase OCD symptoms, this is where I was saying earlier, this really should be decided upon together with the treatment team, right? So you should be talking with the provider to say, okay, what boundaries are we going to set? And you slowly and systematically do it. So if someone's asking 20 reassurance questions a day, we don't go from 20 to 0, right? But we might start by saying, okay, what are you willing to let your parents limit? And they might say, okay, let's start with 10, right? Okay, well then 10 reassurance questions a day. But what that means is, guess what? The harder work falls on mom and dad, or it falls on the caregiver, because that person with OCD is often going to try to ask for 11 or 12 or 13, right? They're going to push those limits. And that's where you have to hold the line to say, I love you, but I don't love your OCD. And we agreed upon this. And so I'm going to stick to the 10, and you've used them for the day.
Okay. So what can you share? We talked a little bit about it regarding treatments for resistant OCD.
You know, the first thing I always want to know is, what does treatment resistant OCD mean, and what does that mean for you, right? So just because I see patients all the time who say, I tried ERP and it didn't work for me. And then guess what? When we do it, it works beautifully, right? Because sometimes it's not about ERP. It might be about the rapport with the provider. Sometimes it is that someone who says they're doing ERP, they're not really doing ERP, right? Or they're doing it improperly. And so I want to know, what does a therapeutic dose look like, and what have we tried? ERP alone didn't work for me, in the sense that, like, traditional ERP, because I was too severe, right? So outpatient ERP wasn't going to work for me. Does that mean I was treatment resistant? No, it was, I needed a bigger dose, right? That wasn't enough for me. It's kind of like, if I need to lose 50 pounds compared to 10, the way I'm going to have to approach my weight loss goals is different, right? And so I needed inpatient level of care. ERP was still what worked, right? But it looked very different when you're doing it intensively all day long compared to 45 minutes once a week. So I want to know, first of all, what has been a therapeutic dose that you've tried, and have you tried various options, right? So if traditional ERP isn't working, are you adding medication in with an OCD specialist? Are we looking at higher levels of care? And once we've kind of gone through the gold standard, which is like an effective ERP dose for your diagnosis and severity, as well as a combination of medication that's evidence-based, right, and a good therapeutic trial and dosage of it, then we can start thinking about other interventions, right? Sometimes we need to use other therapies in conjunction. And then, of course, there's other options for us to always consider, whether that's some sort of like neurosurgery options and different things that exist for OCD treatment as well.
Okay. Someone shared with me recently an article on deep brain stimulation therapy for OCD. Can you talk about that briefly?
Sure. So deep brain stimulation, also known as DBS, has been around for quite a while. It's a very effective treatment modality for OCD. I think the efficacy it shows about like 60 to 70% of people that get DBS have a huge reduction in symptoms. DBS is not a first-line intervention, right? Dr. Wayne Goodman, who's one of really the pioneers of DBS, he's right here in Houston at BCM. I worked with him for a long time, an incredible guy, right? You don't start with DBS. You start with ERP. You start with lots of medication options, adjustments, and trials. But DBS is certainly a great option. I've seen many patients who were treatment resistant, right, where DBS changed their life. And after DBS, they were then able to engage in ERP and get freedom from their OCD symptoms.
Wonderful. All right. That's very hopeful. Okay. So this is a question about transitions. And again, it's phrased from a parent's perspective. But again, thinking about transitions for any caregiver and their loved one. So this person said, my child's about to go off to college soon. How can I best support them and their treatment journey from afar?
Yeah, I think it's a great question. And the answer, as I keep saying, is it depends. And what I mean by that is, what do they want? Yeah. Right? How do they want you to be involved? I've got some patients who go off to college and they have a shared Google Doc with their family members, and we put their exposures on that Google Doc, and family members see it and help them touch base to see if it's going well and what it looks like. And that's helpful for that individual with OCD. They want family to be involved and family to kind of be checking in, but they don't necessarily want to have to email them every time we meet and say, hey, here were my homework goals. For some patients like myself, I will tell you, I didn't want my family involved in my treatment when I was becoming independent. I was like, I want to do this on my own. Like, if I need your help, I'll let you know. So it really depends. What does that individual want and need? And it's important to talk to them versus assuming, right? I think a lot of times we just, we know them enough. No, like, they're becoming independent. They're going off to college. It is important to give them that independence and ask them, I'd like to make sure I continue to support you in your OCD journey. What do you want that to look like, right? What can my support look like? Do you want me to be a part of your therapy process, to check in? Is that annoying to you, right? What does it look like? Because every one of my patients has different ideas and different ways that they want that navigated. And so again, it's about it being collaborative and patient-centered. We want to teach patients to become their own provider. That is the entire goal of treatment, is that I am teaching you skills and tools that you get to use and keep for the rest of your life, that you can utilize anytime you need them. And so as a parent, I want you to support them in that journey to independence, not enable them in the sense that, if they become so codependent on you being a part of their OCD treatment and journey, that can also sometimes be treatment interfering because they're not able to navigate the use of these tools and interventions on their own independently.
Okay. So I want to, then it's so interesting that you have this lived and professional experience around OCD. And so I'm going to go into that lived experience a little bit. And if you were giving advice to your 20-year-old self who was finally able to start attending college after previously struggling with severe OCD, what advice would you give?
Oh, it's a tough question. Yeah, I talk a lot about this. A lot of us with mental illness, right, we can function and still struggle. And some of us can function really well, right? I could be struggling tremendously with my OCD right now, and I could still hold this position and do a great job and compartmentalize, but be falling apart, right, nights and weekends and during my free time. Thankfully, I'm not in that spot right now, but I've been there. And when I was 20, I was in that spot. I was somebody who went to college and barely kind of was keeping it together, right? I was struggling with OCD severely, depression, anxiety, you name it. And so the advice I'd give myself would really be to embrace treatment more. And to, I think the problem is that when I was first diagnosed, I went to treatment, I got better. And then I relapsed when I was 17, this is when I was 15. When I was 17, I relapsed, I was pretty sick, and I went back to treatment. And I didn't get the same results that I did the first time. And it's because I wasn't feeling as motivated or willing. I was really struggling with acceptance of having a chronic mental health condition for the rest of my life. I was really struggling with, why do I always, why should I put forth so much effort if I'm always going to have to do this and I'm always going to have this struggle, and I just want to not have OCD. What I didn't realize is that I subliminally was accepting this message that having OCD meant I had to suffer forever. And I truly believed that. I will tell you, until actually late in my 20s, maybe even into my 30s more recently, I really believed that if you lived with OCD, at least a severe level of OCD, you always were going to have this really big struggle. And so because I had been told so many times that OCD is lifelong, it's chronic, there's not a cure, that was how I conceptualized it. And so I conceptualized that if I could function, even if it meant barely surviving because of how much I was struggling, then that was good, right? That's what that meant that things were good. And I should be happy with that or okay with that. I'm in a totally different place in my life now, right? I have transitioned to a place where I understand that having a mental health diagnosis does not mean we need to accept suffering. And we can have freedom from our illness despite our diagnosis. And I wish at 20, someone would have told me that. I wish I would have had examples of that. And I wish I would have believed that. And so I hope that young adults, and I tell everyone in our clinic here, I hope that people can believe that people like myself wouldn't be doing this work for a living if I believed you had to suffer forever.
Thank you.
Absolutely.
And I mean, your lived experience hopefully is being that model for younger folks that are being diagnosed. So you're bringing hope just by your work, and you're sharing your story like this.
Well, thank you. I hope so, right? That's the goal of it for sure. Makes it worth it.
Yeah. Okay. Just a couple more, and then it looks like we've got a couple that have come in.
And we'll answer, and just so y'all know, feel free to put any in the chat, and we will do our best to get to them today. We'll certainly get to a lot of these ones that are here.
Yeah. Great. Thank you. So OCD can consume the whole family. So the person in that primary caregiver role, how can they best support all members of the family? If they can, what kind of tools or strategies do you have on that?
It's tough. There's no doubt, right, that whoever is struggling gets the spotlight, in the sense that you have to extend more of your resources to those in crisis than those who are not. With that being said, can you still be intentional, right? My mom talks about this. My sister and I are only 14 months apart. She's older. And, there's no doubt that first of all, my parents both work all the time, and, they own businesses here in Houston that they've always been very, very busy. And when I got sick, that was their priority, right? It was kind of the first time that like work and all that didn't really matter, right? Addressing my mental health and my safety became priority, which was great. But I can only imagine what it felt like for my sister or my brother, where it's like, hey, but like I have needs too. They might not be as urgent, but like, why aren't those being considered? And so my mom tried to be intentional with spending individual time with my sister. And what I will say, and she will say, is you have to find and develop a team. Right? My mom got lucky that I had a couple really close friends who did understand my OCD, that she could ask them to, spend 2 hours with me, and she could go do nails with my sister, or go take her to go get ice cream or whatever, right? It might be, but that was important. It was important for my mom to have a break, as it is for any of you that are caregivers, but it was also important for my siblings, right? To be able to have a breather, because as you know, OCD and mental health, it consumes all the space, all the energy when someone's in the middle of their battle and really struggling. And so I think that's really important. And then the second piece is education and support. I got lucky because when I was sick, my sister was so close to me that she'll tell you, she never really was jealous or upset, because she was so worried about me. She saw her sibling falling apart, and she knew that it wasn't something I wanted, or it wasn't something that I wouldn't do anything to get rid of. And so she had a lot of empathy, right? It doesn't mean it was easy, but I think it was important that she was kept in the loop, and that she did understand. Like, I think some parents try to like shelter siblings from seeing the struggle, which I think is good to a degree, but it also is good for them to be able to see it enough to have empathy, to understand, right? She knew that like I wasn't trying to be loud or being disruptive or doing something to get attention because I wanted it, that it was something I wish I wasn't getting attention for.
Yeah. Oh, okay. So I only have one final question, but it sounds like we've gotten quite a few in the chat. And this is, again, this is a hopeful question. How do you keep motivation and hope in this journey where OCD waxes and wanes?
Yeah. I want us to start with something that isn't as hopeful and turn it into it. So what I always say, and what Dr. Grayson says, who I love, and if you have a loved one with OCD, you look into a lot of his work, especially his book, Freedom from OCD, it's amazing, is he'll always ask the question, what has OCD taken away from your life? Right? And we don't like to ask that, because I don't really want people to get stuck in, well, here's the list. But what we do is, once we make that list, we immediately turn that into our greater good, right? So I want to fight OCD because I want to regain the friendships, the career, education, right? All these things that OCD took. And I cannot speak to how critical it is. You have to have a greater good, a purpose for why you want to do this work. Patients will hear me talk all the time about what is your goal? What is your greater good? And they're like, well, I don't know, to get better. Nah, that doesn't count, right? We all want to get better. No one wants to suffer, right? I know that. But I need to know what you're working for, because the work isn't easy, right? Treatment is not easy. It's not fun. It's not overnight, or none of us would be struggling. It's difficult. It's hard. And you have to keep in mind what you're fighting for to be willing to engage in that fight, if that makes sense.
Oh, makes total sense. Okay.
Sorry, I kept seeing like a ring in my camera. I was like, what is that? So I think that's critical. So I tell people, I actually have this like super simple worksheet that I've made that I ask people to fill out, that it says greater good at the top. And then it says short-term goals. And I want you to list 3 goals that are within 6 months. And then long-term goals, like 5-year goals, 2 to 5 year goals. And then I want you to list what are the OCD symptoms that will get in the way of you being able to achieve those goals if we don't address them. And then we start to think about ways we can specifically address them. Because again, I want the work that we do to be intentional. I don't want, right, it's not, oh, I want you to get rid of your OCD to get rid of it. It's, I want you to get rid of your OCD so you can live your life. So you can do those things that OCD has taken away. And now we have a bigger drive, bigger motivation to do that hard work if we know what we're working for. So it's critical.
Yeah. Okay. So Liz, there are questions here. Would you like me to read them to you and in that way, or would you like to just read them yourself? It's totally up to you.
Yeah, I'll start with all the ones in the comments, and then any that weren't in the comments that I don't get, like that we need to also get to, let's just put those in the private chat, and I'll let you do those, Jenny. So okay. I'll start. A lot of you just had great comments, and so thank you. And I know this will be recorded, and there will be places that it is. Katie at 634 asked, what SSRI medication is typically started in combination with ERP? I am going to avoid that question. I'm sorry, Katie, but because I'm not a psychiatrist, I never answer medication questions because this really is going to be specific based on the individual, right? So a psychiatrist is going to want to gather the history and understanding to really decide both the SSRI to start with as well as dosage. And so there are OCD specialists I recommend, OCD specialty psychiatrists that I would recommend starting with. Again, you can also go to IOCDF.org, and there's wonderful articles written by psychiatrists that talk about the different medications and different options that I would recommend that you take a look at. I know there was another question about space. There it is. Is space recommended for spouses? So, I think absolutely it is intended for caregivers. So anybody who is, it was originally developed for parents of young children. And over time, we've started to think about the way space can be used for adults suffering as well with OCD, whether that's for a family member, a spouse, you name it. So it absolutely could be a great resource for spouses, definitely. The next question that I see is, we can function and still struggle. I agree. How do you help little ones under 10 accepting doing ERP? Nixie, this is a great question. It all comes down to providers, right? There are some of us that specialize in working with kids and adolescents as well as adults, and we have background and training in that. We can treat kids as young as 4 years old and be really successful with this type of treatment. With that being said, it needs to be tailored to kids, right? Treatment should be fun. It should be more games. It should be really a bigger focus on language that we use. We're not going to talk about habituation or ERP with a child the same way we do with an adult, right? We're going to, maybe with a kid, we label their OCD. They want to name it a monster name or whatever it is, and we're using different analogies. But it's really about teaching them the same thing, right? We're teaching them how to face fears. And if you think about that as a parent, you do that innately anyways, right? When your kid has something they're afraid of, whether it's a thunderstorm or a dog or whatever it might be, when it's not overwhelming, right? You're able to work through that with them. You're able to help slowly have them address that fear. You don't build that fear up, right? We break it down. And that's the same thing we want to do in OCD treatment. And so we can teach them these tools. The younger, the better, right? The preventative care is always better than reactive care. And so we can teach them these tools and teach them to you as well, so that if OCD shifts or it changes over time, you know how to adjust the way that they would face the fear versus actually making the fear grow by behaviors. Carla, I hope the same thing, and I hope that you'll be able to get your loved one the care that they need. Kevin said, please explain how de-triggering environment is not accommodation. I'm not totally sure what you mean by this question, so I'm going to guess. If you're saying how would de-triggering an environment not be accommodation, I think if you are removing all things in the environment to not trigger the individual, it is an accommodation that you would want to talk to their therapist about, because that's not useful, right? It's hard for family members to live in a home where they can't use or live the way they want because of the potential triggers for someone else. So I would say that is an accommodation that you want to work together to be able to address. If what you mean is by intentionally not triggering someone, how is that not an accommodation? So I'm a big believer in never intentionally triggering someone, right? So if you know that that pink blanket is contaminated in my mind, going and putting that on the place I'm going to sit, that is intentionally triggering me. And therefore, like, I would not, like, that's not fair game for me. Triggers should never be surprises. They should never be unexpected. It should be something we both agree upon. We don't want to kind of provoke OCD. Sorry, I'm seeing that you're clarifying it. You mentioned when returning from inpatient, the environment should be de-triggered. Okay, so what I mean by that is that in inpatient or intensive care, in residential or any intensive treatment care, we should be working on the triggers at home while we're in treatment. So it does not mean, I don't want you getting rid of all the triggers to make them come home to a safe place, right? Because now we're promoting OCD, but I want them to be working on the triggers when they're here. Well, how can they do that? Send us some of the stuff. And if it's a piece of furniture, you can't send it. Okay, take a Kleenex, wipe it on the furniture, put it in a bag and send it to us so that, with, again, guidance of your provider, there's ways for us to slowly work on addressing those home triggers, even in our environment. It shouldn't be that you have all these triggers at home and the first time you think about addressing them is when you go back home after care or treatment. Thank y'all so much. I love the comments and feedback. How do I feel about online ERP therapy and can it be as useful? Do you recommend OCD? I think online therapy can be as useful, right? We may not have as much research to back that up. And of course, again, I think it depends on severity level. Most of us who do online therapy aren't going to do that for 5-6 hours a day the way we can if you need this level of care. But if you think about it in general, right, intensive or just even home visits are something that are really useful and successful, but not a lot of providers used to be able to do. Now we can do that in every session if it's virtual, right? And so a patient with contamination OCD, the fact that I can be in your home where you have these triggers and be doing active work with you because our sessions are virtual is a huge blessing and a huge positive win in treatment that in the past it was hard to find someone who would do home visits. So I think it can be really useful. Programs like NoCD can have wonderful providers. Again, I want you, no matter where you're seeking treatment, to make sure you understand their background and their experience with OCD and their training, but can absolutely be very useful and very successful. How do you know when a teen is ready for an outpatient center versus therapy and psychiatry with the formality and regularity of a 6-week outpatient program? So Katie, this should depend on the program, right? Any good program or any good provider, period, should always be assessing if the treatment they're doing is enough, is correct, or is too much, right? So I should be telling a patient immediately when they're ready to start stepping down to twice a month with me, or they are ready to rotate off. I should be talking to them about it. If what we're doing is good, we should be talking about continuing at that pace. If what we're doing isn't enough, we should be talking about increasing that dosage and what that might look like. And if my program is correct or a different program, right? Giving lots of options. And so I would really want you to work collaboratively with the treatment center and to really talk about what that looks like. A lot of us who do intensive treatment, we would like it to taper down. So if possible, we would want someone to move from residential to a PHP, sometimes to IOP before they move to outpatient care. Not always feasible, not just for finances, but because of COVID, a lot of us don't have day programs open where people can come and go and different things. But what does that transition look like? The therapist should be working together with you and y'all should be coming up with a really good strategy. Leslie, I'm going to probably skip your comment, but what I'll say is that I don't believe there's been any research to show psychedelics, specifically psilocybin as a treatment intervention for OCD that's effective. So I am really strict. Even TMS and other stuff that has been more researched and is coming out, right? There could be some benefits to TMS or deep TMS and certain interventions, but we don't have those as our gold standard for treatment, right? Our gold standard for treatment continues to be ERP with medication for OCD. And so I want specific medications, right, which are often SSRIs. And so I'm really careful to think about trying new age stuff when what we know is we have treatments that are really effective and work really, really well. I certainly want you doing and considering those first. I wonder if the adolescent intensive OCD program is available at McLean. Virtual doesn't work. So Judith, I apologize. We currently only have a virtual IOP for adolescents. Our in-person residential support and PHP is for adults here in Houston. And so because our virtual IOP for adolescents, you have to be in Texas. McLean Boston does have a child residential program. Rogers Memorial in Wisconsin does have a child residential program. And then Rogers and other programs do have in-person PHPs across the country. You can go again to IOCDF.org to learn more. Yeah, so Lisa, I would certainly recommend, right, it's okay to keep looking for providers and psychiatrists. If you're wanting some that are specifically trained in genetics and different things, like, see, they're out there, and look for them and see if you can find them, especially when we're in an age where you may be able to see someone not in your city if virtual is an option. What is required for a psychologist to be able to practice in various states? So psychologists can join a group called SIPAC, which if they're a part of SIPAC, it would allow them to treat patients in any of the SIPAC states. I think state regulations are continuing to work on this. We know that I believe it's a disservice for us to not be able to practice across state lines. I also understand why the regulations exist and why they're there for safety and different reasons, but we'll see what happens. I think COVID and virtual world has certainly opened our eyes to different opportunities. Michelle, there are incredible providers who specialize in autism and OCD. I actually just did a great webinar with both an individual with autism and OCD and a provider on with IOCDF. You can go to iocdf.org/peace of mind, and you can learn more about our virtual programming. You can also go to their YouTube page to find that specific video that I'm talking about. I don't know of any residential or intensive programs that specifically do both, but many of us have providers who can treat both OCD and autism. So many patients with OCD and autism do come through our programs and can be very successful. And when I say ours, I mean any of the OCD residential programs, but I don't know that there's any specific intensive programs only for cohorts of individuals with OCD and autism. But there are many of us that are OCD specific that have patients with OCD and autism. Again, a really good program should be doing a thorough assessment before somebody is accepted and really should be determining if we'd be a good fit, and if not, helping with some referral options of places that might be. Suggestions for getting a teen who's private to open up and share their thoughts with parents on whether they think their ERP is working and how we can better support them. I think it's about just kind of asking in a non-judgmental but open way how therapy's going, and if they feel like they're getting relief, and are they starting to experience some decrease in their symptoms. The second piece is observation, right? Are you seeing them start to increase different functioning that previously they weren't doing, right? If a child is now going back to school and they weren't going to school, or they're starting to re-engage with their friends that they had withdrawn from, right? Are we starting to see some signs like that would be indicative that OCD symptoms are reducing to a different degree? Of course, also any observation of decrease of rituals. The second piece is, I think you said a teen, you can talk to their provider, right? If they're under 18, you can call their provider any day and time. And, obviously we can't always answer any day or time, but right, we should be in touch or communicating, because you don't need a release of information if they're under 18. And so I would highly recommend that, right? Calling and talking to the provider and just saying, just want to check in, right? They don't really want to talk to us a lot about it, and that's okay. We want to support them. What does that look like? And how do you feel like they're doing? 100% something you should ask. I know we have some private questions, so I am going to try my best to jump through as many as I can. If people need to hop off, this has been amazing, and we will continue to give resources. Barriers to access to care, not having an approved insurance plan. So I want you, if you're struggling to find providers due to financial costs, I want you to look in your cities and places to see if there are any specialty programs. So programs like ours, programs like any academic programs that have OCD centers, almost always have sliding scale options, because we are a training institute, right? We're training students, we're training individuals under amazing clinicians, and they're offering great services. So there's often sliding scale and different options if insurance isn't accepted. So definitely look into that. Again, IOCDF.org, when you click find providers, you can also sort out if there's any that do sliding scale. Like you can click sliding scale, Medicaid, Medicare, different options, and it will pop up and specifically show providers who offer that as an option. The next question is, I have a 19-year-old daughter with OCD. She's on medication, which makes her hands tremble. Is it possible to treat OCD without meds? I worry about her taking the medications in long term. First and foremost, definitely talk to the psychiatrist about side effects, right? You should definitely be communicating to them about this concern and if there's other options, and there should be different things they can try. The second is, you don't have to have medication to treat OCD. You have to have ERP. You have to have behavioral interventions, right, which is ERP. Not everybody with OCD has to use medication. Some people might start with the gold standard, which is ERP and medication, and want to taper off, which can certainly be a possibility. So it's not a requirement. Of course, don't stop overnight, and you really want to make sure no matter what, they're with a really strong OCD behavioral therapist who specializes in behavioral intervention, including ERP, so that they can get that support. A recent college grad with OCD PANS PANDAS AE, whose second year PhD clinical psych student peer is doing more harm than good, discouraging treatment with licensed MDs and therapists and doing her own therapy. What can we do? This is a good question. It's a tough question. For those who don't know what PANS and PANDAS is, it's pediatric. It's when often after a strep throat or a strep infection, OCD onsets really quickly and pretty rare, but happens. And oftentimes individuals with PANS or PANDAS afterwards can continue to see OCD symptoms. If it's after 6 months, we often know they need ERP treatment. So what I'm going to ask this individual, what I would say is, are they getting specialized OCD behavioral therapy treatment? So is that clinical psych student at an OCD specialty center? And are they doing really good OCD treatment? As far as the medical interventions go, I think it varies. There is an incredible organization that focuses on PANS and PANDAS that I would recommend that you go through. I think it's called the PANS Network or PANDAS Network. You can find them online. I would start there to really make sure, if you feel like you're needing support for both OCD and PANS PANDAS, that you're going there and getting somebody who can understand both. All providers, whether you're a therapist or an MD treating PANS or PANDAS, should be willing to collaborate and work together. I always think it's a red flag if we're not willing to collaborate with one another. With that being said, I myself have seen many patients who medical professionals are taking them down a route that I don't think makes the most sense therapeutically, where sometimes therapy might not be being encouraged, or they're not necessarily being collaborative, and they're going down routes that might not make as much sense. And so, I never want to say one's right, one's wrong, but we should be willing to collaborate, work as a team, and make sure you're going through people that have really good specialized background and training and a strong reputation. So again, IOCDF, lots of great support there when you're looking at education and support. PANS Network, right, a known entity, and really kind of working collaboratively and together. What's the difference between, I think it was DBS and TMS. So DBS is deep brain stimulation. This is where 2 electrodes are implanted, and there's a pacemaker that is implanted as well, where there is stimulation. TMS is an in-office procedure where you're getting magnetic stimulation, but it is through like a helmet that you're getting the specific intervention during like a time frame that you're in the office, and then that's taken off and it's done, in the sense that you have to get it more than once. TMS is not like you go once and get it. The treatment is a certain dosage for a certain amount of time, but it's not connected to you, compared to DBS is implanted, and it is kind of offering continuous stimulation. So that would be some of the main differences. Certainly DBS is more invasive than TMS. So many people will do TMS before they would consider DBS as something to keep in mind. Thank you. So happy to be helping. My son has both schizophrenia and OCD. It's very blurry at times. What dominates his struggles? Any advice on where to seek effective help for this combination? That's a tough one, right? It's tough with any comorbidities, because what I typically say is we need to treat whatever's primary, right? And within reason, right? If somebody has schizophrenia, it should always be treated first, in the sense that we need to be treating any sort of active psychosis before we would be treating OCD, because how else will we differentiate what is what? Same when you think about something like PTSD, very commonly comorbid with OCD. I need to treat PTSD first because I certainly don't want to be treating OCD symptoms and triggering trauma or triggering PTSD. And so I think it's a hard question. I don't know of a lot of individuals who specialize in the treatment of schizophrenia and OCD within one person. But what I know is that there's a lot of amazing clinicians in both fields. So like, for example, in Houston, we work a lot with Methodist Hospital, Dr. Ben Weinstein, who's incredible with schizophrenia. And he works a lot collaborating with us that we could work together, right? It can be a team, but it wouldn't necessarily be one provider doing both. And so I think really look at academic centers and medical centers where there is more, not just comprehensive, but a team approach and this kind of multidisciplinary approach so that you're working together. My son is 16 with moderate OCD, still able to go to school and socialize, but gets stuck at home. He refuses to acknowledge OCD or get treatment. Do we force treatment while he's under 18 and it's not severe, or wait until he's willing, knowing that he may not reach that point? You're asking me. I think he should seek treatment. I've never heard somebody tell me I sought treatment too early. I hear all the time, I wish we would have gotten treatment earlier. And so I don't think that you'll ever regret, especially if it's a good provider and therapist, right? If our OCD isn't severe enough that we need treatment, a good provider, right? Again, I can't speak for all because they're not all good, but a good provider should be telling you that. Like, hey, here's some signs and symptoms, here's some resources and tools, but like, I don't think they need treatment, right? I'm not going to take somebody some money or take someone's time or a spot from someone else if this person doesn't need treatment. But it's never going to hurt to start giving someone tools and education, even if they don't necessarily need it at a certain level. But waiting, right? Why would we wait till it gets worse? Right? My push to that question is, if you had cancer, would you treat it when you first found out, or would you say, okay, I'll give it 6 months or a year before I start treating it, right? You would never wait, because why? Well, cancer grows. OCD does too. Mental health does as well, right? It will continue to grow and get worse without appropriate treatment. And so I always say, if there's an opportunity, especially to see a good provider, the earlier the better. No 16-year-olds want to go to treatment. I want to just make that clear, right? Like, I myself, who was in years of therapy, even though I knew it, I understood it, I loved my provider, I did not want to go to treatment, even when I was early into adulthood, even if I knew I needed to, right? Because you don't want to accept what's going on. You want to be doing other things, right? That's normal. And so I want to normalize that it'd be very rare for someone who's 16 to be excited about going to treatment and talking about it. I'm going to get to the last three because I don't like leaving anyone unanswered. So you talked about specific outcomes of OCD treatment. What would that look like? Great question. We traditionally, for somebody who needs outpatient level of care, we should expect about 12 to 16 sessions before we'd really see a significant reduction and a really good, not just increase in functionality, but understanding of OCD and ability to function and live their life the way they want. What does successful treatment look like? It depends, again, right? If someone is coming to my residential or our residential support program, I don't expect that they leave without any OCD, because I'm typically going to discharge them to outpatient levels of care and they're going to be tapering down, but they don't necessarily need intensive. They don't need 8-10 hours a day of treatment anymore. And so we're kind of tapering down compared to someone who sees me once a week. I'm expecting them to leave my outpatient level of care on a much different level, because they're not transitioning to other care. They might be going to a support group or something, but not necessarily continuing outpatient treatment. So it really depends, but no matter what, I want the outcome to be that the person has a good, sound understanding of treatment, of how to do it on their own, and what it would look like. Right? I don't want anyone leaving any level of care without understanding conceptually why we're doing this treatment, what it looks like, how to apply it to all different types of OCD in case we have a different trigger. But you should expect us to be able to return to independent functioning. Treatment is not done if we're still codependent on others. Treatment is not done if we can't start to live our life and achieve our goals. And that is what we should expect, right? My ability to go from inpatient care to doing what I'm doing now should not be an exception. It should be the norm. And I believe that wholeheartedly, or I wouldn't be doing this work. Suggestions for getting a teen who is private to open up and share their thoughts with parents. Again, the more we can create a safe space and the more we educate ourselves and become inquisitive and want to learn more and want to understand, the more people are willing to share and to be open. I'm also a big believer in introducing them to other people. Consider or encourage them to attend a support group. As a parent, attend a support group. You need to meet other parents with kids with OCD. You need to meet other spouses if you're a spouse of someone struggling with OCD. It is so important that we all get support and that we're collaborative. Lisa, thank you for sharing. It sounds like a great resource that you were able to share there. I think we got through them all. So yeah, so hopefully we were able to answer as many as possible. One last one came in, so I have to answer it, and then we will stop there. My 23-year-old daughter is angry all the time and expects attention all day. In our home, it's me and my husband and daughter, and she intentionally ignores my husband. It's very hard living and trying to pay attention. It's like she expects me to ignore him. I think this doesn't necessarily sound like an OCD behavior, right? It could be lots of different reasons that this is going on, and maybe they live with OCD, but this is going on as well. This doesn't sound like it would be the OCD unless like your husband is contaminated or there's something like that that's causing her to avoid him or struggle with talking to him. Either way, this needs to be approached. You can't live in a household where people walk on eggshells and where now it's also interfering with your relationship with your husband and you're between a rock and a hard place. And so engage in treatment, come up with behavioral interventions to be able to address this, because we can't accept, right? Life can be disrupted and will be disrupted by mental health in many different ways and reasons, but we don't have to accept disruption forever. We can work together, right? And it's not one versus the other. It's working together as a system because we all want healthy functioning for the entire family unit. Well, thank you.
You did it. Amazing. Well, my goodness, Liz, thank you so much. This has really been incredible. Thank you so much for partnering with us on this talk.
It's my pleasure. I truly love it. And I hope that I was able to share some insight and perspective. And what I want to leave with no matter what is hope, right? I know we talked a lot about treatment and a lot of you are struggling. So we're answering these questions in the middle of struggles. I want you to know that help and hope are always available. And I know there's many times in our life where it's hard for us to see that. It's hard for us to believe it. But I promise you it is true. And there is incredible resources. Whether it's Courage to Caregivers, whether it's IOCDF, whether it's other organizations that can directly work with you and your loved one and what they're suffering with. Connect, build a community, and advocate for care. Don't give up that hope that good care exists and it can be found. And if you have future questions, you want me to answer them or you want to get them answered, please go to iocdf.org/peace of mind. I do a live event with them almost every Wednesday at noon Eastern time, and we answer questions live, and we'll continue to do that throughout. So there's lots of ways to engage, and I hope that I can see a lot of you in our bigger OCD community.
Yeah, great. Thank you so much. Thanks everyone for being here.
My pleasure. Thank you, Jenny, and thank you to everyone who made this event possible.